we'll be talking about physiology of oxygen transports. And to help us to appreciate the physiology of oxygen transport, it will also be nice if we actually discuss a little about oxygen, the properties, the history, before we delve into the physiology of oxygen transports. Now, oxygen, we all are aware that is a colorless, odorless, tasteless gas, which is essential to living organism. Not just only that, it is also vital for the functioning of every cell in the body. Oxygen, once taken, is actually transported to the mitochondria, where it is utilized in order to involve in aerobic respiration. And not just only that, is the most commonly administered drug in anesthesia and critical care medicine. It also aids resuscitation and also provides life support for artificial ventilated patients. The fundamental of oxygen therapy is nothing but to restore the tissue oxygen tension towards normal. So during the course of this discussion, we will actually have a clear view of what this oxygen tension is all about, because that actually explains the bulk of physiology of oxygen transports. Now, the first time, according to the scientists, oxygen first appeared in the earth around 2 billion years ago. But scientifically, the credit to discovering oxygen has actually been shared by three chemists. One is the Englishman, Joseph Priestley, who was actually the person that did the first research in order to discover oxygen. But however, he never published his reports until 1774. But by then, another man from Sweden has actually done another similar research and was able to discover oxygen and made his publication known to the world by 1771. Lavoisier is another man, a Frenchman, who actually also did some research and was able to discover oxygen. In 1968, it was discovered that oxygen can actually be bottled up in a cylinder. And that has actually aided or modified the way people administer general anesthesia as a result of that. Not just general anesthesia, including critical care medicine. Oxygen was first liquefied in 1883. And when you liquefy oxygen, it helps you to store large quantity of oxygen. By 1885, George actually used oxygen in order to treat or manage pneumonia, giving rise to the use of oxygen in acute care medicine. By 1907, NASA catheter was discovered, and this has aided in the administration of oxygen. Still in 1907, John Scott Haldane was also able to invent oxygen mask. Oxygen tent came on board in 1920. All these aspects has helped in oxygen therapy. But during the First World War, oxygen was actually used primarily in order to treat the poisoning by phosphagen. But in 1970, Tako Ayaji invented pulse oximeter. With the invention of pulse oximeter, we've been able to modify oxygen therapy. With that, we'll be able to monitor how patients respond to the oxygen therapy and all the rest of them. Not just only that, pulse oximeter has also improved lots of practices in medicine and anesthesia and critical care. But Brodus, Professor Emeritus, with time was able to give a clue that we can actually include oxygen monitoring as part of the fifth sign in managing any patients in the hospital. In 1970, oxygen concentrator was invented, and over the years, there have been lots of modifications by companies in order to make it portable for utilization. There are several properties of oxygen we are all aware. For example, oxygen, we know is tasteless and odorless, is vital for life. And not just only that, it comprises 21% of the atmospheric air gas. And the boiling point is about minus 183 degrees centigrade. The atomic weight is about 16. It can be stored in cylinders or bulky supply system. Now, let's talk a little bit about medical oxygen production and supply. Photosynthesis is a natural way of producing oxygen. The plants make use of sunlight and carbon dioxide and liberate oxygen to the atmosphere. But industrially, oxygen can be manufactured through fractional distillation. During this process, oxygen is separated from other components of that and then get concentrated to give us medical oxygen. The target is actually to produce about 99.5% or 99.8% medical oxygen. However, in most of the low-resource countries like Nigeria, most of the oxygen plants are able to bottle up to 97%, with 3% being more of like the impurities. And this has actually been of some kind of issue because at some point it tends to affect the oxygen sensors in the mechanical ventilators. This gas pipeline the gas is actually compressed to about 500 per square inch and flow through a pipe of 4 to 12 inches in diameter. There are several ways of getting it to the end users, either by compressing it and moving it through insulated tank trailers or liquefying it and also moving it through pipes to get to various hospitals where they are being utilized. But in our environment where we practice here, most of the hospitals have oxygen plants. They are being bottled and transported to the various sections of the hospital that requires the for their daily use of oxygen. The cylinder we use in bottling oxygen is actually made up of molybdenum steel, and they contain this oxygen in a compressed way of about 137 bar. Every country have their own color coding for oxygen cylinder, helping us to differentiate the oxygen cylinder from other cylinders. And there are lots of oxygen cylinder. We have the size E cylinder, which we usually attach to an anesthesia machine. We call it pin in there somehow locally here, but it's actually referred to as size E cylinder or emergency cylinder, often attached to the anesthesia machine in such a way that when the supply from the pipeline, the pressure has dropped, we actually switch over to the emergency cylinder. We also have the JH and all the rest cylinder, which are actually kept used to bank oxygen, kept in the oxygen room, connected to the manifold and distributed to the various sections of the hospital that requires this oxygen utilization. And the J cylinder can contain up to 6,800 liters of oxygen. The gas pipeline actually is designed with copper alloy materials and is distributed to various sections of the hospital with its outlets. And it's not just only that, it's bacteriostatic, source preventing degradation of this oxygen gas as it moves through this pipeline, and is distributed through the pipeline at the pressure of 4.1 bar. Now, remember that the oxygen is bottled at 137 bar. And for it to get to this patient through pipeline, it drops to 4.1 bar. That means other mechanisms play their role in order to reduce this pressure. So we have pressure reducing valves that tend to reduce this pressure so that it won't be dangerous to the patient. These are the examples of the oxygen cylinders available to us. And this is an example of how oxygen is stored in the liquefied form in a very big tank. And if you look at the diagram, you notice that is stored in this big tank. And liquefying oxygen helps us to store large quantity of oxygen. Then it can now be bottled up and sent to the various sections of the hospital that requires oxygen. But this is not readily available in our own environments. We also have oxygen concentrator, which has made it possible for us to deliver oxygen even at homes. Remember that it was discovered in 1970, and over years, there have been lots of modifications with oxygen concentrator. And it has also made it possible for us to take care of critically some patients that are dependent on oxygen even at home. How do we achieve this? The concentrator takes in air and removes nitrogen from it, leaving only the enriched oxygen-enriched gas, which is now delivered to the patient. There are several ways. We have one of the mechanisms is by using pressure swing absorption technology or by nitrogen separation membrane technology to separate nitrogen and then concentrate oxygen-enriched gas, which can be delivered to the patient at the rate of 5 to 10 liters per minute. And it can deliver up to 90% oxygen. Now, if you look at the diagram, you will see the conventional oxygen concentrator. In recent times, these have been modified, making it portable so that some patients can move around with oxygen concentrator. The two diagrams there are nothing but pictures of oxygen concentrator. Now, having gotten this mental view of oxygen, the production, and how it's being bottled up and delivered in the hospital, let's talk a little bit about the physiology of the transport of oxygen. Now, there's what we call oxygen cascade. It's nothing but a series of steps. Partial pressure of oxygen takes from atmospheric air to the mitochondria, which is located inside the cell, where the oxygen will be utilized. In the early years of 20th century, there are two physiologists, Adolf Fick and Paul Betz. They actually advanced this knowledge, helping us to understand that, have the understanding that the basic oxygen physiology is described in terms of oxygen tension. Now, they use those units to describe the difference in oxygenation between arterial and venous blood, and that defines the oxygen transports. They also help us to understand that if oxygen is given at a very high concentration for a very long time, it can also lead to some toxicity. Oxygen is actually transported by the blood, either in combination with hemoglobin or in a solution with plasma, dissolved in plasma. Now, hemoglobin takes care of about almost 98% of the oxygen transports in the system, whereas the dissolved one is about less than 2%. Now, oxygen tension provides the driving force, driving pressure for this oxygen diffusion into the cells and also combining with hemoglobin. The resting body, there are certain terms we really need to have an idea about so that as we are explaining the transport of oxygen in the system, we'll be able to have a clear picture of it. Those are some of the factors that can actually influence the amount of oxygen in the blood. Let's talk a little bit mathematical explanation. Understanding these aspects will help us to really understand what quantity of oxygen we really need. Now, oxygen content in the blood is nothing but the sum of oxygen bound to hemoglobin and the oxygen dissolved in the plasma. Oxygen, which is 1.34 times, equal to 1.34 times Hb concentration of the patient, and then the oxygen saturation. The 1.34 is actually referred to as constant, which is nothing but Hoffner's constant, okay? If we are to work on a patient whose hemoglobin is about 15 grams, let's do some calculation about this to know how much of the oxygen this patient hemoglobin will be able to contain. If it's equivalent to the resting level of oxygen we actually require to function. Now, if we take the hemoglobin to be 15 grams, a patient that has hemoglobin of 15 grams, the oxygen saturation of this patient, normally, when we'll be talking about the oxygen dissociation curve, we'll be able to understand that oxygen can be, the hemoglobin can be saturated at the level of 98% if everything is in good condition. Now, if we are taking that 98%, 1.34 times 15 grams per dl of this hemoglobin times the oxygen saturation, which is 98%, that's 0.98. That gives us 19.7 mil per dl, or 197 mil per liter of blood. So for every liter of blood, we have 197 mil of oxygen incorporated into it. The hemoglobin is able to carry. Now, like as I mentioned earlier, if everything is in good condition, for example, we said this binding capacity is about, the saturation is about 98%. There are other factors that play some role to make this dissociation curve not to get up to 100%, like methemoglobin and carboxyl hemoglobin. They take a particular fraction. And if somebody is a chronic smoker, and that means the value can also be higher than that, making the saturation of hemoglobin lesser than 98%. Now, we've been able to understand that hemoglobin oxygen by every liter of blood, we have 97 mil. Now, let's talk about the one dissolved in the plasma. This is actually determined by the solubility of oxygen in plasma and the partial pressure of the oxygen tension. At normal body temperature of oxygen dissolves in 1 liter of plasma, where the partial pressure is about 1 millimeters of mercury. So this is referred to as solubility coefficients, okay, which is 0.03 mil per liter per millimeters of mercury, or 0.003 mil per 100 mils per liters of mercury. So if we do the calculation, okay, that will now help us. Let's assume the arterial blood, like as we mentioned earlier, the partial pressure of oxygen at the level of the arterial blood is 100 millimeters of mercury. If we incorporate that, that will give us, and do our calculation, our maths, that gives us for every liter of blood, we have 3 mils of oxygen dissolved in plasma. And remember that for every liter of blood, we have 197 mils of oxygen incorporated into the hemoglobin. Now, when we sum this up, trying to get the sum, so the amounts in hemoglobin and the amount dissolved in plasma, that will give us 200 mils per liter of blood. So we have 200 mils of oxygen by each liter of blood. And now let's look at another calculator that will take into consideration the cardiac output of this patient. We all know that at a particular minute, there's a quantity of blood that is being pumped out from the heart. Now, the amount of oxygen delivered to the tissue per unit time is actually what we refer to as oxygen flux. Now, if we look at the arterial oxygen content, which we've already done the maths, okay, if we try to incorporate it together with the cardiac output of the patients, okay, we'll not be able to, let's assume patient has cardiac output of 5 liters. If we times the 200 mils we're able to get with 5 liters, it will give us 1,000 mil, okay, of oxygen. 9,849, which is, 1,000 mil of oxygen is available. And remember that at the resting stage, what we actually need is 250 mils of oxygen. So which means the body is designed in such a way that there are lots of reserve available if the patient is in case of times of higher demand, there are lots of reserve readily available for the patients. Now, if we also take into consideration the venous oxygen content, yes, the venous blood also contains oxygen. And if we take that into consideration, we'll be able to also understand that the venous blood also has about 150 ml per liter of oxygen. Remember that the arterial blood has 200 ml per liter of oxygen, whereas the venous blood has 150 ml per liter of oxygen available to the patients. Now, let's have a clear view of both the arterial blood and venous blood, because most of the blood is actually really available in the venous circulation. Now, the oxygen, the partial pressure of oxygen within the arterial blood is about 90 to 100 millimeters of mercury, whereas in the venous blood is about 40 millimeters of mercury. Now, if we take that into consideration, remember that at the arterial blood level, the hemoglobin binding capacity, it can be able to saturate at about 98%, whereas in the venous blood, you have about 73 to 75%. Now, if you remember the maths we've done earlier, we're able to understand that hemoglobin can bound up to 107 ml per liter. The venous blood can bound about 147 ml per liter. The dissolved components in the arterial circulation is about 3 ml per liter, whereas in the venous circulation is about 1.2 ml per liter. So, taking all those into consideration, the total oxygen content in the arterial blood is about 200 ml per liter, whereas in the venous blood is about 148 ml, approximately 150 ml per liter. That's taking into consideration those bounded with hemoglobin and those dissolved in the plasma. Now, taking the cardiac output into consideration, the blood volume within the arterial blood is about 1.25 liter, whereas in the venous blood, it's about 3.75 liter. So if we do the maths, we'll be able to understand that volume of oxygen in the arterial blood, we have 250 ml, whereas we have 555 ml in the venous blood. So if you sum it up, you see the volume, general volume available. This is just the general broad view of what we try to describe so far in terms of physiological oxygen transports. Okay, taking into consideration how oxygen moves from the atmosphere, which is about 21% of oxygen, you have the expired air, which contains about 16.3% of oxygen. At the alveolar level, it's about 14.2%. Then when you take the partial pressure into consideration, from the atmospheric air, you have 160 millimeters of mercury. By the time it gets to the arterial level, it's about 100 millimeters of mercury, whereas in the venous, it's about 40 millimeters of mercury. And we've come to understand that 100 ml of blood contains 0.3 ml of oxygen in dissolved states. Now, let's look at oxygen dissociation curve, okay? This reviews the amount of oxygen saturation at different partial pressure of oxygen value or oxygen tension, okay? Several factors can influence this, but actually oxygen tension is actually the major factor that influences oxygen dissociation curve. It helps us to understand that the tension and the saturation of this hemoglobin is actually not a linear relationship, so to say, okay? Some refer to as sigmoid, okay? Now, if you look at the diagram, you will observe that at 20 millimeters of mercury, the hemoglobin gets saturated up to the level of 30-something%, whereas at 40 millimeters of mercury, it gets saturated. Remember that 40 millimeters of mercury, we are looking at venous blood oxygen tension. Now, it gets saturated to about 75%. Okay, Whereas at 100 millimeters of mercury, which is the arterial circulation, the hemoglobin gets saturated up to 98%. So even in the venous blood, there is still some level of saturation, irrespective of the tension being about 40 millimeters of mercury. So that helps us to understand what we are really talking about. So lung at high elevation, like some that live on top of the mountain and all the rest of them, at tension of 80 millimeters of mercury, the hemoglobin is about 95% saturated. Okay, those who live at the sea level, they get the 98% because you have about 100 millimeters of mercury of this tension. Even when the tension drops lower, you still have some level of saturation of the hemoglobin. This is a clear picture of what we try to explain. Okay, at 80 millimeters of mercury, you have 95% saturation. Now, but there are some factors that can affect this oxygen dissociation curve. Some of those factors can make this hemoglobin to remain bounded to the oxygen, okay, the affinity being so high, and some makes it make the hemoglobin to be able to readily deliver this oxygen to any tissue in need of this oxygen. So when the curve moves to the right, it means there is reduced affinity of hemoglobin to oxygen, so it's readily available to the tissue. When it moves to the left, it means the affinity level is very high, it's not readily available. And some of those factors include temperature. As the temperature increases, the tissues, because metabolic rate increases, the tissues will require more oxygen in order to achieve that. So hemoglobin tends to let go of oxygen readily. The same applies to when there is increased level of hydrogen ion, as well as increased level of 2,3-diphosphate glycerates. So these are some of those factors that can affect the binding capacity of the oxyhemoglobin curve, the affinity of the oxygen to hemoglobin, and its readiness to deliver it to the tissues. All right, so this is just like summary of what we've mentioned in terms of the oxyhemoglobin curve. Now, having gotten all this mental picture, it will also be nice to also take a little bit, discuss a little bit how we give oxygen to some patients. Either one medical condition or the other are not able to do well with the ambient air oxygen concentration. We are all aware that the ambient air contains with 1% oxygen. So the main goal of oxygen therapy is actually to treat hypoxemia, thereby preventing tissue hypoxia, which may result in tissue injury or even cell deaths. Okay, so hypoxia simply tells us that there is oxygen deficiency at the tissue level. Why hypoxemia? Help us to understand that there is abnormally low oxygen concentration in the blood. In other words, the partial pressure of oxygen is actually lower than 100 millimeters of mercury or 8 kilopascal. There are 4 different types of hypoxia. We have hypoxic hypoxia. Okay, in hypoxic hypoxia, the tension of arterial blood is actually, oxygen tension in the arterial blood is actually reduced. Whereas in anemic hypoxia, what we are looking at, there is reduced hemoglobin level in anemic hypoxia. In stagnant hypoxia, the problem deals with blood flow, okay? Because blood flow to the tissue is very low, there is lower oxygen available to the tissue. Then in histotoxic hypoxia, it simply helps us to understand that, yes, in this condition, we have a certain toxic agent that oxygen is available, but it's not readily available to the tissue because of either a toxin or something else. I mean, either due to toxin or poisoning, like cyanide poisoning, carbon monoxide poisoning. And there are several indications of oxygen therapy. We have in acute condition, medical emergencies like in shock, sepsis, in managing patients with asthma and anaphylaxis. We also have chronic conditions like patients with chronic obstructive pulmonary diseases. They also require to be on oxygen therapy at a particular concentration. We also have surgical need for oxygen, as well as when a patient is undergoing anesthesia. Now, before you give oxygen to the patient, there is need for preparation. We need to clinically observe this patient. Is this patient in need of oxygen? And our monitor will help us to do that, looking at the saturation, looking at the vital signs, blood pressure, and all the rest of them. Especially saturation will help you to know whether this patient needs oxygen. Apart from saturation, we also need to do arterial blood gas analysis to know if patient is in deficit of oxygen. There is hypoxia, and there is need to correct this hypoxia so that we don't allow the patient going to start developing some tissue, cell injury or tissue damage. Now, we also need to talk to the patient about whatever care we want to give to the patient, which is not readily done in this environment. And we really need to encourage this, okay? Because most of the time in our environment, patient, they just attach oxygen. We need to talk to the patient and help patients to be part of their management. And when we have started the oxygen therapy, there is also need to monitor these patients. We had the arterial blood gas analysis we did when we started. We also need to serially analyze this to see whether we are making any improvements, okay? And when we are giving oxygen to the patient, yes, we start with 100 liters, but the target is actually to go as low as possible. Remember that the ambient air contains 21% oxygen. When we put patient on 100% oxygen, we tend to cause some other problem, expose patients to risk of oxygen toxicity. There are several devices we use to administer oxygen, and they are grouped in different ways. We have performance, based on performance of the device, like fixed or variable performance. In fixed performance, where the device is designed in such a way that a particular concentration of oxygen is given, like a venturi mask. Whereas in variable performance, yes, even when you're planning to give 100%, patient also breathes in ambient air, so it tends to dilute the 100% oxygen coming from your oxygen cylinder. Okay, so because of that, we refer to them as variable performance. We have the nasal prong and simple face mask. Then we can also group our oxygen admission device. It can also, we have patient dependence. So this requires patient effort in order for it to be functional. Or it can also be patient independence. We have flow delivered by, we can also group based on the flows. We have low flow, we have high flow, okay? The low flow, nasal prong falls into the low flow, although some nasal cannula recently with advent of COVID and all the rest of them, okay, can also be used to give high flow oxygen. We have jet ventilation, okay? So the next grouping is degree, based on degree of dependency, where we have low dependency, like face mask, nasal prong, medium dependency, like CPAP mask and equipment, and high dependency, like non-invasive and invasive positive pressure ventilation. All right, this is just a picture of what we've tried to explain. Patient on nasal prong undergoing surgery, and another patient, medical patient, who requires oxygen therapy through a nasal prong. And this is a simple face mask where we will refer to. And we have non-rebreather face mask. This one has the ability of giving a high concentration of oxygen because it has a reservoir bag. Okay, it can tend to reserve some oxygen. Then the venturi oxygen mask is designed in such a way that it can deliver a particular percent of oxygen. For example, if you look at the diagram there, the green color code can give you 24%, and the dark green can give you up to 60%. It depends on the environment. It comes in different color code and it's written on the body how much percent of oxygen. We tend to use this to manage most of the time patients with chronic obstructive pulmonary diseases, because they also need some form of carbon dioxide in order to continue breathing and stimulating their respiratory center. If we wash up all the carbon dioxide, they tend to become dependent. Okay, for the venturi mask, it works on different it has Bernoulli effect and then venturi principle, which helps it to, which is being designed on this principle. Now, when we're talking about Bernoulli effects, it just helps us to know that when a fluid is flowing through a constriction, it gains kinetic energy, losing potential energy. So as a result of that, pressure drops. So when this pressure drops, the venturi principle comes into play. The second fluid, that means it tends to entrain some stream of air into this already fluid that is flowing. Now, in this situation, we are referring to, let's assume we are giving a patient, oxygen is flowing through the venturi mask. At the constriction, the pressure drops. It tends to entrain ambient air, diluting the already oxygen coming from the tank. Then it's designed in such a way that based on the one we're using, it can now dilute it to the concentration we want to get to the patients. Okay, so the air is entrained inside. As the oxygen flows in, the pressure drops, air is entrained into the system, thereby diluting to give a particular percentage of oxygen which is readily available to the patient. And it also increases the flow. So when we're using the one that is white color coded, it will deliver 28%. So if we set it at 4 liters per minute of oxygen using our oxygen regulator, at the end of the day, it tends to entrain oxygen. The eventual flow rate becomes 45 liters per minute in order to be able to give you this 28%. If we are going by 6 liters per minute, it goes up higher. When we are using, if we want to deliver 60%, if we set at 12 liters per minute, eventually gives us 24 liters per minute. So that's how the venturi mask work. We can also use bag mask ventilation to deliver oxygen to the patient, especially when we are doing cardiopulmonary resuscitation. We can also give patient oxygen through mechanical ventilator. Oxygen also has some complications. Patient can develop oxygen toxicity, or can end up having retrolental fibroplasia or absorption atelectasis. And that is why we try as much as possible not to put patient on 100% oxygen. Once patient stabilizes, we try to tail down, targeting about 30% or 21%, which patient naturally should be on once the problem has been sorted out. In conclusion, oxygen is actually transported in the blood, mostly bound to hemoglobin. We have small amounts dissolved in the blood in plasma. And with the principle of oxygen tension we mentioned about, remember that for more oxygen to be dissolved in the plasma, that means the oxygen tension needs to be increased. And based on that principle, that's how hyperbaric oxygen therapy works, to dissolve more oxygen to the plasma, making it readily available to the patient in the times of need. And hemoglobin oxygen saturation decreases when the tension decreases, and also when the pH decreases, when temperature increases, and 2,3-diphosphate glycerate increases. So each of these conditions can increase local oxygen demand and make oxygen readily available to the tissues. These are my references. I want to thank you all for listening to this lecture.